Then I have to move both my things. Yeah, they were good.
Or do I need to stand?
Yeah, that's okay right
Is this
there.
okay?
Yeah, that's great.
All right. Hello, everyone. Thank you for coming. It's good to have you. It's kind of weird standing here in front of this, but thanks for being here. Want to just recognize a few people. Want to recognize Colton first. Just so you guys know, Colton is now one of our shared leaders, kind of taking over for Jen. So we are excited to get him in the office to help us out. As you know, he's a total stud, awesome nurse, leader. So we're excited to have him. So give him crap next time you see him. We also have some awesome anniversaries. We want to celebrate these people. Val, 20 years, so that's really cool. Shelby Pollock, 10 years with Intermountain.
Nice.
1 month with us? No, more than that. 3 months with us, 10 years with Intermountain.
That's awesome.
And Gina Carell, I know you're on there. Congrats on your 5 years. We will have something nice for you guys. Also wanted to recognize Jody. Is Jody on there?
No, she's not right yet.
Oh, darn it. Well, just want to tell you this story. Teresa sent this to me about Jody. So was this over the weekend? Was it
was
Vicky?
Monday.
It was on Monday when we saw 200 people. Vicky White was the trauma nurse. She was totally slammed, busy. One of her patients was this happy but confused elderly patient from a care center, right? Mm-hmm. And she was supposed to be discharged and they're waiting for transport and everything, but she just kept wandering around and leaving, and was probably a falls risk too, or right? And anyway, they were trying to figure out what to do because they were so busy, and Vicky had gotten a trauma, right? You were heading into a trauma. And Jody had kind of overheard what was happening, and she said, "Oh, I'll take care of this little old lady." So she went and made her some tea and got her some crackers or something. And you know how Jody is, she'll set up shop in the middle of the hall with her computer on wheels, and she sat this grandma by her and fed her crackers and tea and just visited with her. And did she do a conscious sedation with the grandma in the hallway?
In one of her rooms with grandma in the hallway. It was amazing.
And she was just so sweet with this old lady, and was such a big help. And you guys know Jody's always like that.
Yeah,
She's always willing to jump in and help, and she just makes such a difference in the department. So we love you, Jody. Hopefully you'll see this later, and we'll definitely recognize you. All right, well, we're gonna try to make this quick and painless. So let's see. That was all I was supposed to talk about, right? Vicky's gonna talk about tissue analytics. Oh, sorry, you want me to run that?
Oh, well, it was.
Here, I got it for you. Can they see that okay?
Mm-hmm. So they're rolling out tissue analytics, a fancy word to just mean taking photographs of wounds. When should I use tissue analytics? Right now, Wound Clinic is saying full thickness wounds requiring a treatment plan. For example, patients are going to be referred to the Wound Clinic because their wounds are super complicated. Per Wound Clinic, we do not need to be taking pictures of our regular lacerations that are just here for sutures, road rash, skin tears, things like that. As of right now, they said those aren't the things we're focusing on. So simple instructions, I will also email this out. There'll be some more helps around too. You have to prime the patient, that's their words for it, but what it really means is you open up FirstNet, go to your patient, and pick tissue analytics in the main menu, and that's called priming the patient. That opens up their chart. Then you use the little iPod. These will be stored in the med room, and you pick the Tissue Analytics app, and then just log in with your Intermountain login.
Is there any like password or anything you get?
The password is on the back. It's 2018. Nobody needs to remember that. It's on the back. So when you log in onto the little iPod, find your patient on the list. We had X-Test Amy up on FirstNet, so we find her on there. And then if she's got a wound, we're gonna add a wound until you just pick the plus.
Does it, for the patients, does it just load like patients you're assigned to? Or?
I think so, and I've
Probably
only
the
been able
ones
to.
that are primed, probably.
You have to prime the
Gotcha.
patient.
Okay.
This is worthless unless you prime the patient. Then you'll take a green dot, these will be stored right next to the iPods in the med room. The green dot needs to go near the wound. The green dot is what the computer thing uses to gauge the size of the wound. So you put the green dot by it, snap the photo, and click submit, and then
Like you stick that dot on there?
On
yeah,
that person.
near the wound, not on the
Okay.
wound. It goes on the skin. They say to put it as flat as possible so the software can
Measure it.
read and measure better. Click submit, and then magically it loads into iCentra on their wound list and has all the data and measures it and stuff. It's pretty intuitive. There'll be some helper sheets near the iPods too. We'll keep them in the med room, wipe them down with purple wipes after each use, keep them charged. We'll have a multi-unit charger in there, and then the passcode's 2018, which is on the back of all of them. So
Can I ask, like, what if you had like, I don't know, a domestic abuse or child abuse and the kid was all bruised up or anything like that? You probably
So,
wouldn't use the same process, but
because of the way it, and I don't really know the answer, but the way it loads into iCentra, it loads
It's loading
into a
as a-
special wound list, and if you go deeper into this, it's like percentage healed, and so that's a good question. I don't know the answer. The wound care clinic has left us phone numbers. We can call them and
So
ask
probably for right
specifics.
now, just have the scribes take pictures
For right
and
now,
load it
that
into the
kind
chart
of
like they've
stuff.
been doing.
Use what the scribes are doing, yeah. As we get, they're just barely rolling it out to the rest of the hospital right now. Wound clinics used this for several years, and we'll kind of feel our way, but that's a really good question, so.
Michelle, you're up to talk about PPE changes.
Okay. All right, so we have a few exciting changes. I feel like they're pretty exciting with the PPE that just happened in the last few days. So we have not been able to get rid of masks and goggles yet. So, but we're hoping for that. In some certain circumstances, that part's changed. So you can look the guidelines up on the A to Z of Intermountain, but it's a little trickier to find. I made a few copies and put them on my desk if you want them, or you can just look at it. But really, or you can just watch this. But the big things is that, like in here, masks and goggles not required anymore when you're in an auditorium, closed doors. If you're vaccinated, if you're not vaccinated, they would like you to social distance from everybody else, 6 feet. So in order to do that,
And wear a mask.
and wear a mask yes, as well, technically. And then also, in patient care areas, that's just the same. We're still gonna do masks and do goggles in the patient care areas, which includes the room. So a little bit to our discretion, but mostly they're considering the ER hallways are still part of the patient care. We would it did say hallways though on here, we didn't have to, and elevators and hallways if a patient's not with you. So we're leaving that kind of open to discretion, like on where you are in that, like if you're on the back hallway of the ER and there's no patient rooms back there, so like huddle or, but when you're going down the main hallways of the ER, you need to have a mask. No, you do have goggles. Yeah, sorry.
I thought we were doing, if you wear gloves, you wear goggles.
Yeah.
Yes, that's what RER
Oh, okay.
is. I'm just if
Okay.
you were to speak to like say Joint Commission, like,
Okay.
it would be that I will wear
goggles.
goggles in the patient care areas, including where a patient may go. So that means like triage or down the hallways. But what we're doing is if you wear masks, if you wear gloves, you wear goggles.
Okay.
So the other thing, so like this meeting, we don't have to. If you're in a non-clinical building, so say if we have like if we,
Sims or something.
like if we have Sims, you no longer have to wear a mask or goggles. And then in outdoor spaces, you don't have to either. So, we have some, but you do have to wear a mask, no goggles on the shuttle. But, so we do have a little bit more leeway. I'm pretty excited. We haven't let it off all the way that Intermount hasn't, but they had originally said they weren't going to let the goggles drop prior to Joint Commission coming. So that's something I'm pretty excited about.
Can you talk about visitor?
But yes, I would love to talk about the visitor policies. So once again, RER is special. And so we have things that rules are a little bit different. So we, as you know, we let our COVID visitors come in. We tell them, like what I say is when I bring them in, I say, you can come in here, but you can't leave the room. You have to stay the whole time. And if you leave, you can't come back, right? On the floors, once they go though, and this is what I want you to educate everyone to, is when they go to the floor, you need to tell your patients and their family members, they will be required to wear full PPE when they go to the floor as a visitor. So they will be in gowns, they will be in gloves, they will be the full
Mask,
shebang,
or else they get
mask,
to go home.
or else they have to go home. So just educate them to that, because our rules are different than what their rules are, and we can speak to that because we're outpatient. We don't know if they're going to get admitted. We don't know what they're going to do, and we do have them stay in the room. But where they're going out into the hallways and going around the hospital, they want them to be in that full PPE so that their loved one doesn't contaminate their clothing, or they're out with everybody going. We just have them go in the room and stay, right? So we have a different rule, but please educate your patients and family members, because the floors are really upset and want us to have them wear that
We finally get to be
PPE.
the nice.
Yeah, we finally get to be the nice guys on something, right? You don't have to, just go in there, stay in there, don't come out until they leave, that's fine. But, so we're a little different, so if you can just educate the family to that, so it's not a surprise when they require them to wear that. Does that sound good? Anything else on that?
It's awesome. Thank you.
Here, we pull it that other.
Let's see, so we go back to email, and then Jen's is right here.
Okay, guys, so staffing has kind of sucked. Sorry, I don't know. We do think it will get better. We're getting some people hired up. We've just interviewed and made offers to 3 experienced ER and ICU nurses in the last week, actually. So we think it will get even better and better and better. But we have heard a lot of controversy about the incentive. So I did a little math so that we can kind of have a reference point for people. So if we look at that next slide, basically if you make $15 an hour and you come back for a fill a need, you get time and a half. And then if you've met your budgeted hours for that week, you get an extra 35%. Then if you do 4 extra shifts in 6 weeks, you also get an extra $400 if you're a tech. So if you do that math, basically at $15 an hour, you're getting $22.50 per hour, the extra 5 1/4 for the 35%. And if you do the full 12 hours, which you don't have to, it's $8.33. So $36.08 per hour, $432.96 per shift. Pretty good money, right? And then for RNs, we get the $800 incentive. So same deal. If you were making $30 an hour, work 4 extra shifts in 6 weeks, you're making $45 an hour for your time and a half. An extra $10.50 for the 35%. And then if you did work the whole 12 hours, you're getting another $16.67 per hour. So $72.17 per hour, $8.66 per shift. Pretty good money. I mean, that's Vegas money right now. So anyway, just so that you can speak to it, I don't know that everybody knows and can take advantage, knew to take advantage of that. You do have to do it. There's some there are some quirks, like some people, if they're PRN, they have to work their 12 hours that week, and then anything extra that they work, they'll qualify for the 35% time and a half, and they can do, if they do 4 shifts, they get the extra $400 or $800. But anybody got any questions about that?
Maybe just remind them how to get the incentive, the 35% incentive.
So the 35%, you need to make sure that the charge nurse writes callback on the staffing sheet. That's all they have to write.
Or you can write it.
Or you can write it. I write it myself, make sure it gets on there. And then also, we're having some technical difficulties over here.
No, you're okay.
Then it's a good idea to do a time card exception and just put 35% exception callback pay. You can choose whatever thing, callback or extra shift that you want. It doesn't matter, right? And then there's a little contract that you print out. I did a bunch of them during Christmas time. And you print it out, write down one shift that I work extra, and then the next time I work a shift. And it can be as little as 4 hours. We prefer it's at least 6, but it can be 4 if the charge nurse sends out an SOS and says, hey, I need somebody to come in for a little bit. Somebody came in for 4 hours yesterday, and it saved us, so it's really helpful. But anyway, you write your 4 shifts on there, make sure that they're over and above your regular scheduled budgeted hours for that week. And when you've got 4 of them, hand it in to Jared. There's 2 places to sign on there. Give it to him, and they send it into payroll, and you get the $400 or $800 on your next paycheck. So
The one thing to be careful about is if you give up a shift or you call in sick and you don't work your budgeted hours, that's where it gets a little tricky, because you won't qualify unless you are working above and beyond your budgeted hours. So just be careful of that.
yeah, be aware of that. You couldn't be like,
So we have a question.
okay,
Will just putting in the time card exception be enough if we forget to put callback on the schedule?
Yes.
but I would definitely encourage you to recheck your time card within that 2-week period when time's gonna get turned in, and make sure all of those exceptions show on there. It'll show extra hourly and all of those little, it shows that you're getting more money on your time card. And if you do have an exception or a discrepancy, you really ought to challenge that within the pay period for it to not give you any grief.
The other thing is if you write callback, you are for sure gonna get the time and a half. Because callback pay is always time and a half. Doesn't matter how many hours you work, you'll get time and a half. Or if you leave that empty and it gets coded as an extra shift and you're short a few hours, you may not get time and a half for all the shifts. So that's why we encourage the callback. It's just a lot cleaner. And that's just like a lame payroll rule.
It's just, when it's my money, I'm more attached to it, so I'm really careful to be like, I'm running callback on there myself.
Right.
So I would encourage.
I
people
would
to do that
prefer,
too.
yeah, that you guys, whoever's working the shift writes callback. Like, don't put it all on the charge nurse. Charge nurses are there to help, but they might get distracted and they don't care about it as much as you do, so.
Well, and sometimes I don't know, like, depending on how you picked it up and all of those things, if it got reprinted or something, I might not know that they're there for callback. I'm okay. Seizure. Anyway, so make sure that you do that. Any questions? Sweet, it'll get better. Soon, hopefully.
Who's up? Janine, do you have a PowerPoint?
No.
Okay.
It's like a little screen.
No, I didn't do it for PowerPoint.
Brilliant staff.
We're just
Sorry.
multitasking with our
Technology.
technology
Technology
deficits
issues right
here.
now. Okay. So a couple things, postpartum hemorrhage, we've had some concerns with that, and it's actually a push nationally right now. They've had some moms that have had postpartum hemorrhage have expired throughout the country, and they found it's because we're underestimating blood volume loss. So the big push is that we now actually need to measure blood loss and postpartum hemorrhages. So there is a diaper scale in the bottom of the postpartum hemorrhage cart, and that'll be hemorrhage cart, that you can pull out and actually weigh your tucks and pads to make sure you're getting an accurate measurement of any blood volume loss, so that you know whether that mom needs a transfusion or not. So make sure we're doing that and documenting it well, that we've actually measured blood volume loss and not just estimating it. postpartum hypertension is our other thing. So postpartum hypertension is anywhere from 20 weeks pregnancy to 6 weeks postpartum. So I know Caitlin just sent out and Jen sent out recently the postpartum hypertension algorithm. It's in the charge nurse binder. It's at the triage desk, so you can refer to it if you can't remember what the blood pressures are, because
It's on the huddle board too.
it's on the huddle board, because the blood pressures are, like, we consider it normal, like, it's not a big deal, except in those, that time frame with pregnancy. So make sure that you are getting hold of the doc, calling labor and delivery, and letting the charge nurse know if you have a postpartum hypertension patient, so that you can get treatment to them right away. And then, fetal heart tones. So fetal heart tones, we talk about 20 weeks with everything else, like can go up to labor and delivery, as postpartum hypertension, or pre-eclampsia. But 23 weeks and 1 day is where we need to do stork bites. Under 23 weeks and under, we just have to do fetal heart tones, or not stork bites anymore, fetal link. 23 weeks and 1 day, we need to put them on fetal link and get a rhythm strip on them. So your fetal heart tones, you can Doppler them. If they get an ultrasound or the provider does an ultrasound, you can document fetal heart tones from that ultrasound as well. Just ask them what they were. But make sure you document fetal heart tones. So.
What if the physician doesn't agree with the treatment in the protocol, we've been asked?
For postpartum hypertension.
For postpartum hypertension, well, the doctor still has to order it, but they need to be able to justify, because they're gonna get all of those postpartum hypertension patients actually get scrutinized, and they'll get to justify why they didn't follow the protocol.
So at the very least, they should have a conversation with the
With the laborist, with
Yeah.
the OB hospitalists, they should have that conversation and determine why they aren't treating that postpartum hypertension. Okay, any other questions?
As the nurse, I would be charting.
Document
right
like
out of that.
crazy. Like it's a very, very high risk category for patient. Lots of suits, lots of things for both those postpartum hypertension and postpartum hemorrhage.
And most of the time, L&D charge nurses have been good at helping us manage those patients. Sometimes
Yeah.
they don't really want to, but for the most part, getting them involved early is
Yeah.
best, right?
Yep, get them called early, even if you call them from triage and say, hey, I have a postpartum hypertension patient. Here's, where they're at in their progress. Sometimes they're like, you guys start them down there. Sometimes they're like, we'll be right down, we'll come help you. And sometimes they're like, just bring them up. So it kind of varies depending on how busy they are. Yes.
For these patients, how are we defining the hypertension? Is it just one blood pressure measurement?
The protocol just says one.
But when I've called, they want me to do more
They
than one,
usually
like
want you to
15
check
minutes
another
later.
one,
Because they're, alright.
but the protocol does not specify that.
A lot of people that come to the ER have an abnormally high
Yes,
Mhm.
they
blood
do, they
pressure
get,
in triage.
and then it's fine in the back.
Right.
So sometimes the labor nurse may ask you, hey, will you recheck it first, and then let's see where it's at, which is fine, we can do that, but we still need to take them back to a room, and like, they're an expedited patient, we should be seen sooner rather than sitting in triage.
And talk about the parameters, because they're not our normal.
No, it's
Triggers.
over 140 of systolic and over 110 of your diastolic, so it's like, yeah, over 140, which we don't bat an eye out most of the time, right? But and these patients, it is a big deal. So, okay.
Greater than 20 weeks gestation and
Greater than 20 weeks gestation, under 6 weeks postpartum. So,
Thank you.
You're up, Colton.
Colton, you're up.
Don't mess up your first time.
That's right.
I'm great in front of the camera. So with the Steward Health coming, we are going to start to have competition with hospitals. And something that we've never experienced in this area is having competition with hospitals, and that's giving EMS the opportunity to take patients to other facilities. So one of the ways that other places make it more lucrative to bring patients to their facility is they have really awesome EMS rooms. I've seen them for myself at Sunrise, UMC, even Primary Children's has a pretty good setup up there. They got frazzles and ours, we used to have one, but went away with the construction. So, and EMS will go to different facilities if they can get better snacks and better drinks, and it's worth it to them. So something we're gonna try and do is bring back our EMS room. We're gonna ramp up our nutrition room to have, we've already kind of started it with better snacks, more drinks, stuff like that. So the thing for us is just we've heard a little bit that staff is kind of kicking them out of there. So please don't do that. Invite them in, invite them to get a snack or a drink. We want to keep those relationships good with them and make them feel welcome and to want to keep bringing patients to us.
And you can have snacks too.
Yeah, you can have some too.
Nice. Party.
We're gonna get done early.
We are.
We're cruising.
Kind of an update of things.
All right, so most of you, if you've worked here for a few years, know that we usually do like a winterish party, then we usually do a summer party. It's really hot right now, and we've waited too long. So that's kind of my only update on it. It's like, if you have suggestions, let me know, but we're thinking we want to wait maybe a few months until it's not 115 degrees outside. Get together, all of us at a park, or whatever you guys want to do. We'll wait till like maybe September, do it more as a fall party. By all means, if there's things you want to do, places you want to go, email me, let me know, and then I'll get to planning something. We'll just do it a little bit later this year.
All right. I think that's pretty
That's
much
pretty much it.
guys. So, hey, just a reminder, we'd love for you to sign up to meet with us for a check-in if you haven't. Hopefully you have that in your phone. And if you're having problems signing up, let me know and we can get you signed up. But thank you for all you do, and we will see you around.
Awesome. I am going to send this link out later via Messenger, so if you've already watched this, don't watch it again, by all means. It's just hard for people to watch YouTube from any of the work computers, so sending it via email is kind of pointless.
That was a short staff meeting.
Thank you. Yeah, that was awesome.